First, thank you for having me. Thank you, IPC. What I did was I just took notes over the last 3 talks, and the fellows are doing an incredible job. So really great mentorship program and really great job to the fellows. But before I start, and I won't keep you long, I promise, but I wrote down psoriasis is a disease of obesity, excess adipose, why? Lipid accumulation, excess lipids, why? Intracellular, thank you for saying that, dysmetabolism, why? Genetic predisposition, Mendelian randomizations, I know that Ravi is here. I do want to speak to you about those because I did my first one in CRP back in 2008. Psoriasis is a disease of insulin resistance. That Hotzmiegel paper was my thesis paper that you quoted. That was my thesis advisor back at MSCE World. Residual inflammation beyond PASI score. Psoriasis is a disease of obesity and dyslipidemia. They define psoriasis. All things that you guys have said. Perhaps the resulting cardiometabolic diseases is not monogenic. I do not, sort of ever want to have the talk that Anne had to give and put together, because that was one of the most confusing sets of data sets that I've ever gone through back in the day as well. This is a polygenetic disease with multiple pathways of dysregulation. So I'm a cardiologist. I've studied human translational lipids for over 20 years now, and it gives me great pleasure to be here. My adiponectin experience is about this. It's maybe 1 paper, 2 papers, but I know that I was asked to comment on it. So I too, like Anne, am going to be a good professor and try to explain the best I can here, because that was a very tough topic and you did a great job. You really did. That was a really tough topic. And here, adiponectin, I want you to just think through what adiponectin might be. And today we learned about GLP, maybe agonism as a way of thinking about psoriasis as a disease of missing something, right, or needing more agonism. Here, adiponectin is going to be an important hormone to think about. These first 3 slides I did for myself, and I'm sharing them with you. They're busy, they're ugly, but I needed to remind myself what adiponectin was. It's a peptide hormone secreted by the adipose, so it's an adipokine. It's produced by adipose adipocytes, transcribed by a gene on 3q7, and it is a glycosylated protein. The protein structure, it has a signaling mechanism. It is a globular domain, which makes it very difficult to drug. And the receptors and signaling make it even harder. When I learned about high molecular weight adiponectin and the different receptors, I turned the other way in 2004 or 5 or something like that. This is what it does, so you can imagine why it's a good thing. So if I try to look at things as good things and bad things, here adiponectin is a good thing. You actually regulate insulin sensitivity, promote oxidation of these things, which pushes them out. If you look at this, you could say, well, maybe this is why my piece of paper with all of the notes actually makes sense. You could tie it all together with adiponectin, but you can't. You can't. I wish I said you could. It's abundant in the bloodstream, so biomarkers that are abundant in the bloodstream are really hard to drug. There's a circadian pattern. We wake up with it more than we go to sleep with it. It's inversely correlated with adiposity. That is what I need you guys to jump on board with me as I give you the rest of this talk, because obese individuals have lower adiponectin, and we're going to use that expansion as our surrogate marker as we go through this. Low adiponectin is linked to insulin resistance, type 2 diabetes, and cardiovascular disease. So I'm going to stop at this last slide for adiponectin and then go into adiposity, because can adiponectin be a target? In short, probably not, even though restoring function looks like it could be attractive. And in preclinical model it works. Look at the challenges on the bottom. It's a complex oligomerization. It's difficult recombinant production. So you think about this as a drug. We may want to look at it as an indirect target, right? And I'll talk about that. Okay. So in 2006, when I met Joel Gelfand on the elevator, I was pushing LPS into healthy humans. And he said, wow, I have a model of inflammation in my patients. And he was very forward-thinking in calling it systemic inflammation. 20 years to this day, I still call psoriasis a disease of systemic inflammation. I'm not going to go through the slide, but it was interesting. We took healthy college students, brought them in, slugged them with LPS. What do you think happened? Ooh, they got inflamed, right? So TNF goes up, MCP1, monocyte chemoattractant protein. You're getting vascular activation in healthy college students, right? CRP went up late. Why? Has to be transcribed by the liver, right? Okay. Whoa, this was crazy. 2009, diabetes says what? You get adipose inflammation in healthy humans. You see their IL-6 go up, their MCP go up. This is all part of immunometabolism that Alvaro was talking about. You see the TNF-alpha fold change, and you see A20, which is actually an insulin receptor signaling protein. But there's more. The proteins actually themselves had transcription and translation into proteins in the adipose. So what we were all taught in medical school, not true. The adipose is not a vacuole of a storage organ. It is active, and if we don't get a handle on it, we're all getting extinct. So this is the insulin receptor substrate pathway. Look at it. You see insulin receptor go up with inflammation. Why? It's asking for something to happen. The substrate goes down because there's no insulin and no glucose. You see GLUT4 go and actually lose its ability. GLUT4 moves glucose across a cell. So if I'm ever going to bore you, that was probably the most boring 3 minutes of the talk. It was at that time, Joel, I didn't know him at this time, but my former mentor, Paul Ritger, was on this paper, and it got into Bill Roberts' AJC. Bill is one of the most talented editors and put together this forward-thinking group. It was at that time that I was a fellow in 9, and Joel and I embarked on what I consider to be a very critical path of mentorship transition into fellowship. And we found that people really with inflammatory diseases at that time were predisposed, but no guidelines would ever put their money where their mouth was and say you had to do something about it. So then this started. I saw that Joel and I had seen that this is happening. We didn't know what to do about it. And I took on, for 10 years, a lab at the National Institutes of Health where I will put this statement up here, Alvaro. Psoriasis is a disease of inflammation, lipid accumulation, and adipose dysfunction. And you'll see here that we made this conceptual model in 14, and it was published in 17, and now it still holds true to this day. Lipids, inflammation, and metabolism, LIM, that's what we want to think about. This is the world's largest cohort study. I'm sorry about the formatting. Oh, geez. It still has an honest broker agreement. If anyone's interested in the data, I'm happy to discuss this with you. We continue to do residual risks of inflammation and adiposity work in this. We've always believed in deep phenotyping, so remember, we're here to talk about adiponectin, right? So this had some adipokines and some adipose biology. You'll see on the bottom right, we had skin and adipose tissue. And boy, is the skin is just, I mean, who said it just a second ago that, I think it was maybe Joe, it's the largest holder of cholesterol in the body. The skin is an organ, right? Don't forget that. And you guys all know that. You guys are dermatologists. So then this is where it morphed. Oh, I'm sorry about my formatting again. This is where it morphed, that we then said it's probably the inflammation. I'll walk you through this. Chronic inflammatory diseases. Joel said it nicely that maybe it's the vascular disease driving the psoriatic disease. So if you kill or take out the skin component of the inflammation, it could be that the other source is still coming from other places. And that's a very big interest of ours. So what we did, I don't know if that middle, can someone click on that middle movie? I think this revolutionized the way that we looked at cardiovascular disease. So I had an offshoot of this in 2006 of Joel's work and how we thought about this being a signal, but then what we really wanted to do was prevent that first event. And really having a patient who has a heart attack in front of you with psoriasis and not having known they had that risk, that pangs me. That really pangs me. It should not happen. People should know that this is a known association, and I believe that Joel had brought up an Australian survey. In fact, Steve Nichols' group in Australia has said 1 in 5 doctors do not understand the link between psoriasis and whole body disease. So that's way too small. Okay, so we have a way of phenotyping, and this is where I can tell you a little bit about adiponectin. So consider that the fat that we measure in BMI, or the obesity we're measuring, consider waist to hip ratio, or better yet, visceral adipose tissue. Over the next 7 minutes or so, I'm going to show you how we don't want to say this is what every patient with psoriasis needs, but using this mechanistic information, we can provide better care to our patients. So in the middle, excess adiposity. There was a small piece below. I think my formatting really did come off. I'm sorry about that. But on below, it was the picture of visceral adiposity, which I'm going to show you. And all of these things are all related. So hepatic steatosis, lipoprotein dysfunction, insulin resistance, chronic systemic inflammation, they all come together. In 2008, along with that group, we then discovered that LPS drops adiponectin, as well as adipokines, fractalkine, as well as leptin, were modified. This is not in psoriasis. This is in diabetes. I started as a diabetes obesity researcher. So these 2 papers were 8. Come 14. I don't have the ability to do visceral adiposity yet, haven't figured out how to do it. And I'm like, well, wait, maybe, just maybe, this adiponectin thing can be looked at. So along with Joel, Abby in the clinic, we basically got 250 patients with psoriasis, put it together, and in every model that I could ever imagine, psoriasis was independently associated with lower adiponectin levels. So clearly there's an epiphenomenon. 2 years later, I had a smart student ask, well, what if we approximated those patients and actually measured their visceral adiposity? And this began our VIP visceral adiposity trek. And what we found here was psoriasis makes you have more visceral adipose. You could even be lean and look good, but you have more visceral adipose. Then in 22, we put together our 3rd VIPA study, and we find that, oh my goodness, a drug that reduces systemic inflammation, that doesn't have ApoB shift or weight gain like Humira or adalimumab, apremilast actually reduced visceral adipose tissue. Oh, this is very interesting. And it was 0 to 16, all the way out to 52, no difference between the two. So when you start it, it reduced it. So here's my disclaimer. In none of the prior studies was adiponectin measured. Therefore, we can attempt to use that as a surrogate, and how I would put that study together is following. So does VAT meaningfully matter? And so, I'm sorry, on the right there was supposed to be actually a picture of the VAT. Someone clearly doesn't want you to see the picture of VAT today. So we took 378 patients and we measured their coronary disease and their visceral adipose. Remember the title of this talk, Can Adiponectin Be Used as a Cardiometabolic Surrogate? If we're saying that adiponectin is tightly related to visceral adipose tissue, I want you to keep in mind visceral adipose tissue may be actually the solution here. So how did we do this? We looked at people who had higher visceral adipose tissue at baseline. And you'll see up front, they had higher BMI, and you can see the quartiles across. They had higher waist to hips, you could see the quartiles across. They had more MET-sin, and this was about 40 years of age, so they're all young. But with high BMI, waist to hip ratio, and an insidious presentation, we all passed these patients, right? The person that I think it was maybe Joel's talk, that guy was a ticking time bomb. He's about to have a heart attack in the next 5 years, and no one wants to call it that. So that's what we found from this. We've got a lot of confidence. Deeper phenotyping reveals these patients with psoriasis to have a somber diabetic-like state. So when I got into medicine, diabetes was soon to be discovered to be metabolic syndrome driven. Then when I got into this field, I considered psoriasis to actually be metabolic syndrome. And if you use that logic, this actually takes really great shape in talking to your patients. You're all going to have diabetes within the next 10 years if you don't do something. Look at their insulin resistance. I'm having you focus on the left. Their HOMA-IRs are that of diabetics. HOMA-IRs over 3 are diabetics. So my visceral adipose patients who are high visceral adipose have lower cholesterol efflux, lower HDL, higher triglycerides and VLDL. Look at their coronary disease, 1.32 compared to 0.95, 35% higher just because of their visceral adipose tissue compartment. What did we find? When you look at what that visceral adipose tissue relates to, it's the things that we know, insulin resistance, visceral adipose, and even subcutaneous adipose. And on the right, you'll see that at baseline, when you had more visceral adipose tissue, you had more coronary disease. But now, equal treatment of psoriasis, worsening that worsens NCB. So imagine you took the same patients that we just talked about, you give them all the same PASI treatment. There is a subset of patients, despite getting improvement in their PASI, continue to expand their visceral adiposity. And when you look at this table, what you'll see is those who worsened their VAT had a 15% increase in their coronary disease at 1 year, which persisted at 4 years. We buried the 4-year data here because it became down to an N of 50, but it still persisted. And then you look at the people who improved their VAT, went down from 1.26 to 1.13. I'm looking at the non-calcified burden. You're improving their psoriasis, you're improving their visceral adipose, and you're improving their coronary disease. So clearly the relationship is there. So can adipose or adiponectin be the target? This is the best I could come up with. Preclinical data supports it. Standard assay testing remains expensive. No widely available adiponectin tests exist. Work on small receptor antagonists is ongoing. The best strategies to upregulate endogenous adiponectin remain attractive, and I pull the call out for Mediso. I really believe that what you saw in MediSo is going to be very important for this group to engage and embrace, because what MediSo showed us was a Mediterranean diet can actually improve this, and I bet you it was because of their visceral adiposity and a reduction in inflammation. So conclusion, adiposity can remain a strong target with the understanding we don't understand fat biology enough to target adiponectin yet, but we do know, and based on some of the work that just was shown by Joel in your group, that this is something we don't understand and we need to embrace it in order to actually get better. That is my real email there at GW. If you'd ever have a patient, a question, or anything that I can help with, located in Washington, D.C., and I still have 2 active practices around the East Coast. And again, thank you so much for this great honor to speak to you about this very exciting and important topic. Thank you.
Well, thank you, Nehal. I think we have time for a couple of questions, if anybody in the audience has any. Well, I can start off. What with other adiponectins or adipokines like leptin?
So leptin, just like incretin, and leptin, just like other omentin, if you will, they're centrally active. So leptin does actually go up in psoriasis. And so leptin is an adipokine. Why it's fallen out of favor, Mitch Lazar's group, the nuclear receptor group, had shown that leptin actually has a few other places of source. So it became a little bit difficult to follow. I still do believe that it has something to do with central appetite control. So again, this disease of excess that we're calling psoriasis, there's about a 5-fold increase in leptin as well.